Welcome again to our webinar. Today we will have a fantastic webinar on a not so common topic, which is skin healing and immune response. The today's speakers are Professor Frederick Naftolin and from United States and Professor Mark Brincat from Malta. And as always, you have to write your question in question and answer. And at the end of both presentation, I will read your question to the speakers. Professor Fred Naftolin is received his MD from the University of San Francisco and his PhD from Oxford. He was chairman of obstetrics and gynecology at McGill University from 73 to 75, and Yale University from 78 to 2000, and research professor at NYU. He is currently a founder of two startups applying a uterine pacemaker to halt preterm labor and developing exosome to pharmacotherapeutics. He has been president of the Society for Reproductive Investigation and the North American Menopause Society, and founding and current member of the executive board of our International Society of Gynecological Endocrinology. Fred Naftolin, dear Fred, you can have the microphone and you can share your screen. He will speak about a fantastic topic.
So good morning or good afternoon for most of you. Today, thanks to the invitation of the ISGE, I'm pleased to discuss with you some views about our integument and how it works, what works it, and the potential role of estrogen in injury. So the skin, of course, is our old friend, but it is not the only thing that covers and protects our innards. In fact, the skin and its contiguous mucous membranes make the coverage of our internal organs and our interface with the external world. This is something that has arisen evolutionarily, and I will talk a little bit about how it could be that we have skin and contiguous mucous membranes. It can only be possible to consider the number of specializations that require to take us from a simple metazoan animal to what we are today, and every aspect of biology is involved in the integument. We can't touch on all of it, but to get through the subject, I will concentrate today on how we developed an integument, and we'll try to concentrate on the reproductive organs. And since estrogen is such an important player in regulating the integument, I will review estrogen and estrogen receptor biology, because the chief actor in all of estrogen action is the receptor, and it's important to understand that. And finally, I will end up with some more or less current questions that we are studying in terms of the response of the integument to injury. How did we develop an integument? It started when we were relatively simple metazoans in the sea. This, I should preface this by saying that this is my own theory. I don't know whether an evolutionary biologist will spring up and say, you're full of it. But we started as simple flat metazoans. We might call them flukes or worms. And then over a period of time, as we were swimming in the primordial sea, we began to fold in some of the surfaces of the generally exposed surface of that organism. And as we folded the organism, the surfaces were internalized. And ultimately, this resulted in an inner tube with exits at both ends. For example, in the gastrointestinal tract, we would have the mouth and the anus, or in any other tract, it would be the same. And this ultimately resulted in all of these tubular internal organs that we have, including the reproductive tract. The outer portion of the organism toughened up and remained what we now call the skin, and the inner portion specialized into various multi-functional mucous membranes. In the one that we're most familiar with is the genital tract, particularly the lower genital tract, the vagina, and the vulva, which are distinct from the skin, but have a contiguous interface, so that we have basically two systems that are connected. This is the connection is a mucocutaneous border, and often has specializations at the interface, such as the teeth, glands, musculature, etc. Anyone who has looked at the genitalia has seen the mucocutaneous juncture. As a result of these two developments evolutionarily, there have been two types of immune systems. Sorry, I'm trying to get something out of the way there. That defend against the outer or external environment. In the most simple one, the one that was internalized, we have the innate immune system, which is pretty much constantly fighting the same problems, mostly bacteria and other seawater-like elements that attack from the inside. And in fact, the inside of these tubular structures within the body are actually more like seawater than they are like the external environment. This innate immune system is present in the mucous membranes, or within the mucous membranes, but on the outside, there's been adaptation. This is now called the adaptive immune system, which is kind of ready for anything that comes from the outside and can defend itself with specialized cells and with antibodies, etc. Both the skin and mucous membranes have estrogen receptors. The estrogen receptors are ER alpha and ER beta, shown here as ERA and ERB, and that is part of the system of function and defense. Injury to either of the two systems will result in scarring, but in the case of the mucous membranes, there are no keloids formed, while in the case of the outer environment exposure, there can be scarring anomalies. We call them keloids. We'll get back to them in a while. So I'm going to quickly now run through the estrogen receptors and estrogen action, because it is critical to the function of these two elements of the integument. I will essentially read the things in front of you, and then I will show you some examples. The primary agent in estrogen action is the estrogen receptor. It is not the steroid or the compound that binds to the estrogen receptor. It is in fact the estrogen receptor. The estrogen receptors live in the cell, and they're kept in an inactive form by a cap, a molecule that's called the heat shock protein, which keeps their stereotypical form. And in that estrogen receptor that's kind of floating around in the cell, there is a channel which leads to specific amino acid lined pockets that can capture. Sorry, I want to get this out of the way there. That can capture molecules or what we call ligands, and these molecules, such as estrogen, estradiol, or its congeners, tamoxifen, raloxifene, these are called ligands, and when they are bound to the receptor, this is known as liganding. The receptor, when it ligands something in its pocket, this disturbs the shape of the estrogen receptor and basically pops off the heat shock protein that has been holding it in shape. The result is that now the now deformed or reformed estrogen receptor can dimerize or join with other estrogen receptors, either estrogen receptor A or B, or alpha or beta, to form dimers. These dimers, the pairs of receptors, then can act on the genome. They transfer into the nucleus, and they then address the DNA in the nucleus, looking for what is called estrogen response elements. This whole process is guided by tissue-specific co-transactivational or transactivational factors that are, because they are specific and because of the possibility of multiple receptors, ERA, ER alpha, and ER beta, different receptors being together, and of course, because of the difference in the ligands, you can see there is almost an endless possibility of the results of all of these things. Finally, when the dimer is allowed to reach the estrogen response element of the gene's DNA, the dimer turns on or turns off the gene's transcription, which regulates protein synthesis. While there are also membrane-bound estrogen receptors, we're not going to talk about them today. They function in a different way. Here is a cartoon that was furnished by Professor Tommaso Simoncini, and you can see that at the top is a ligand, in this case estradiol, E2, and the ligand enters the cell. The ligand in this case is a lipid-soluble ligand. Estradiol is soluble in lipids, so it can freely enter the cell, and it finds a receptor. The receptor can either be ER alpha or ER beta, and when it finds that, it deforms the receptor, pops off the HSP90, so it finds the receptor and it pops off the heat shock protein, which then allows it to dimerize. So if it was on an ER alpha, it might dimerize with either an ER alpha or an ER beta to form the dimer that will enter the nucleus and will then be addressing the estrogen response element on the gene, and that will lead to regulation of transcription. And you can see the cluster of different factors It's called co-transactivational factors that are tissue specific and therefore define what is going to be the effect on transcription and whether there, in fact, is even going to be an effect on, on transcription. You'll note again that I have purposely made the ligand, in this case estradiol, a minor player, and that the major player in this is the estrogen receptor. And here you see Tommaso's version of how you can get different dimers. So you have alpha-alpha, alpha-beta, beta-beta. So we are talking about a system that has almost unlimited possibilities, that is tissue-specific, and decides whether the outcome will be more or less transcription of proteins that are going to be shipped into the cell and then are going to regulate mostly as enzymes various intracellular processes. So this is how estrogens really work, and this is why we can think of tamoxifen or raloxifene or estetrol or whatever as being really equivalent to estradiol in terms of their meaning for estrogen action. It is only in terms of quantitatively, whether there's a lot of them around and more likely to ligand to the receptor, or whether they are more have more affinity for receptors, in which case they are likely to, as it were, outperform other ligands. And all of these things are ongoing even as we speak. So the system is extremely complicated, but one should never be concerned about thinking of something other than estradiol as the active agent here, because it's not. It is the receptor that's going to dimerize and address the estrogen response element. Here, from our own work, are some is a computational example of what's done. This is all done on a computer, and you can see on the upper right frame that you see the arrow showing a channel in the receptor, which allows the ligand, in this case, we're showing it with two ligands. One is estradiol, which is in the middle and in the nice colored ones. And the other is another ligand, diphenylhydantoin, which is dilantin. You have all read or used it for convulsions. It's an anti-epileptic drug, but also it is a SERM, selective estrogen receptor modulator. And you can see how with computer modeling, we can show the little gray figures addressing, in this case, 3 amino acids in the channel that is leading to the pocket. And so in this case, since one of the amino acids that can be addressed is the lysine 540 in the channel of leading to or within the beginning of the pocket, when that happens, if that amino acid binds that ligand by electrostatic attraction, then a very critical element, the so-called helix 12, which is the dark blue, is not allowed to close the pocket, and therefore the receptor is essentially inactivated. In that case, we would have to say that while estradiol can get into the pocket and address other amino acids, in that case, the diphenylhydantoin, by blocking the closure of the pocket and therefore the deformation of the receptor, becomes an antagonist. And in the lower frame, you can see exactly how this happens. We are looking at the effect, an estrogenic effect measured by optical density, and you can see how estradiol has a pronounced estrogenic or agonistic effect, while in the next line down, when you add phenytoin, you block that effect entirely because you have blocked the ability of the ligand estradiol to cause closure of the pocket and therefore the subsequent actions of the receptor. And therefore, we term both of these as SERMs, estradiol and diphenylhydantoin. And in the next, right shortly below it, you see tamoxifen does the same thing. We term all of these as selective estrogen receptor modulators, and it should reinforce to you the idea that the active principle in estrogen action is the receptor, and that it takes these different ligands called selective estrogen receptor modulators, including estradiol, to regulate the action ultimately of the estrogen receptors. Now let's, once we've established who the characters are, the integument and the mucous membranes and skin that make up the integument, and the SERMs that act through the estrogen receptors, we can then start to look at the effect of SERMs on wounds. So here is a picture from Hardman showing a wound made in a mouse. The exact same wound is made in each of the frames that you're looking at. And if you look at the green arrows, the little green arrows are showing the closure of the wound after, I think it is, say, 3 days after the original wound was made. And you can see that in this mouse, it was a female mouse, the intact mouse has closure. You can look at where the green arrows are. But if the mouse has been ovariectomized, there is a failure of the closure. And if you treat with estrogen, the closure is something like what would be expected in the case of an intact animal. In fact, if you add other SERMs, tamoxifen or raloxifene, to the ovariectomized animal, they are about the same, but you'll notice now that there's a difference in the type of wound closure. Under the case of estrogen and raloxifene, you have not only closure, but you have a reconstitution of the superficial epithelial layer, while tamoxifen appears only to just foster the closure of the wound, probably through the kinds of connective tissue that Dr. Brincat's going to tell us about. But there's a failure to reestablish the epithelium, and in that case, the scar might very well turn into what we call in the case of the tamoxifen, you can see that you will form a scar with poor epithelialization, and therefore that scar might become what we call a hypertrophic scar rather than a very typical nice-looking scar. So estrogens, or SERMs, better term, SERMs are important in wound healing. Here is a picture, and I'm sorry, I had to blow up from a paper the actual illustration, so it's not so easy to see, but I'll guide you through it. Here is what happens when estradiol's effect is dependent on the reepithelialization, what I just discussed with you before. And again, you have the green arrow showing the closure. In this case, you have DPN, which is an ER beta agonist, and you have PPT, which is an ER alpha agonist. And you can see that it appears that the DPN, the ER beta agonist, or the SERM that is triggering ER beta, is giving a better closure than is the ER alpha agonist. And so the conclusion Campbell and all reach is that it is the type of receptor that is the one that is going to have the main effect on wound closure. And in this case, we would have to say that DPN is a better actor on closing wounds because it is an ER beta agonist. Here are some of our own work. This is looking at human scars, comparing normal. You can see on the left a normal scar with 2 layers, well, 3 layers actually. The short little eye is the epidermis. Then you have below it the dermis, and then below it you have all of the collagen that is making up the subdermal area of the skin. Again, I'm sure that Dr. Brincat will want to talk about this because this is primarily collagen. In the middle, you see what is called an hypertrophic scar. That's often a scar that's been under tension, and you see that it is a very similar to the regular scar, except that it's a little bit more stretched out, and that the epithelium is a little bit more prominent, and all of the elements are a bit more prominent. So that's a hypertrophic scar. On your right is a keloid. And keloids, as you know, are little pouched out areas on top of the skin where the healing has included the overgrowth of the scar. And you can see in this case, as the double arrow shows you, there is only a small dermis subepithelial area, and mostly the keloid is made up of collagen. So now we know what the target is for keloids, and our interest became piqued because people began some years ago to apply intradermal tamoxifen, and caused regression or prevention of keloids. Keloids are extremely common, particularly among people of color, and it is worthwhile understanding how one might protect against keloid formation, and you can think of what we are doing in that way. So let's now turn to the other element of the integument, sex skin, because sex skin is the mucous membrane portion in the reproductive tract, and sex skin is really a further development of this evolutionary theory that I showed you before, that results in a folding and tubular structures within the body that are interacting with what is in the body. In this case, in the reproductive tract, we have the endometrium and the endometrial surface. We have the inside of the tubes. We have the vagina and the vulva and the mucocutaneous junctions. And all of us understand that in menopausal women, that means that the ligand, estradiol, is absent or missing, we have a lot of shrinkage of that mucous membrane. And that results in um, a number of illnesses. In the case of the vagina, of course, it results in all kinds of bacterial infections. And in the case of the vulva, it results in pain and other symptoms that can get in the way of a satisfactory marital relationship, as well as being itself problematic. All of you know that treating with the SERM estradiol generally is protective of this, kind of reinflates those shrunken areas. And so we know that a SERM must be working. If it's working, there must be estrogen receptors because they are the active principle. And this is just a cartoon of the different organs of the reproductive tract, all of which on their interior are lined with mucous membrane, which is important in the different functions. I won't go through them for the sake of time. Here is a general characteristic of these mucous membranes. They have tremendous elasticity. They have strength. They can reconstitute themselves. A good example of this is the endocervix, which goes from being a tight little button during pregnancy, holding in the products of gestation, and then opening up, stretching, extending to allow a 10-centimeter head to pass through what was originally something less than 1 centimeter. They have a bland response to healing with minimal scarring, and this is very characteristic of the mucous membranes of the genital tract, and most important for, well, not most, but important for our discussion, we never see a keloid formed in the mucous membrane of the genital tract. When I was teaching, I had an outstanding bet with the residents. Anybody that could show me a keloid on the perineum, I would give them a case of beer. I never gave anybody a case of beer. You don't get keloids in mucous membranes. The same goes for the mouth. I've spoken to many dentists. They just don't see keloids. They see scars, but not keloids. The swelling is due to water imbibition. And of course, we've talked about the stretching and so on. This happens on the surface. Here's a very old picture from Ferris, who was a pioneer in veterinary medicine. And you can see in B the genital swelling that comes in the monkey during the time of estrogen rising at ovulation and until the time of menstruation. To get a better picture of this, here's something a little more contemporary. I think these are baboons that I found on Google Pictures, and you can see the swelling of the sex skin. So this is really mediated by estrogen, and it's very waterlogged tissue that is spread. This is mucous membrane. This is not skin. We call it sex skin, but it is not skin. It is the mucous membrane. And of course, we have the classic from Lila Nachtigal, the classical picture of what the skin of a menopausal woman with atrophy. You can see it on the left, and the same patient after 1 month of estrogen treatment. And you can see that both the epidermal layer with its many keratinized cells and the subepidermal layer, which is now more waterlogged or better hydrated, contribute to this recrudescence of the genital mucous membrane. This is very good and I think very interesting, but brings us back to the question of keloids, which is somehow a little hobby of mine, and I'm still got my case of beer. So let's talk finally about keloids. This is the human vagina, and you can see it has dermis and epidermis, but not very much of the subdermal collagen bundles and ropes that you saw on other biopsies. It is my thought that perhaps it may be that it is in the width and the presence of the collagen layer that the effect of estrogen occurs without the formation of keloids. And so we are presently looking at ways to somehow sabotage the effect of estrogen on collagen in order to perhaps stabilize or prevent or treat the presence of keloids in mucous membranes. You wouldn't expect to see them, but in the skin. Of course, there is the element of the innate immunity that would have to be dealt with as a protector. We don't know much about that. Thank you for your attention. I'm looking forward to hearing how Dr. Brincat is going to tell me how to deal with the collagen.
Thank you, Fred, for that fantastic lesson and for that concept of the importance of estrogen in that mucous membranes and how this can modify the response, the inflammatory response in the healing process. And now we will go to Professor Mark Brincat. Please, Mark, can you open your, share your screen? Professor Mark Brincat will speak about the effects of hormonal contraception, including COC and hormone replacement therapy on collagen turnover. Mark Brincat is a consultant obstetrician and gynecologist. He was a clinical chairman and head of the Department of Resident Professor in Obstetric Gynecology, University of Malta, Malta Associate Dean and Professor in Medical Education at in London. His research interests are the collagen disorders, the menopause and climateric, the bone metabolism, and gynecology and endocrinology. And Mark Brincat is also a member of the board of our International Society of Gynecological Endocrinology. Thank you, Mark.
Thank you. Thank you very much, Andrea, for inviting me to join this wonderful session. And thank you, Professor Naftolin, Fred, for your beautiful first talk. I'm just trying to click all the right buttons here. I think we're getting somewhere, but we don't need to see my face. Okay, good. Right. So mine is a bit different from the very beautiful presentation of Professor Naftolin. Let me just see if this works. Yes. Okay. So I've got no disclosures really. I'm going to concentrate a bit on the effects of oral contraceptives on bone, muscle, and skin, and then finish off with estrogens, because we know we have a lot of work on estrogens, but not enough on oral contraceptives. And a lot of the stuff we take for granted about the effects of oral contraceptives and ethinyl estradiol, for example, on collagen in the skin, muscle, and bone are not necessarily correct. So just as an introduction, we've got a contraception that is very widely used by women of childbearing age now. It's been around for about 70 years. And basically what we have here, as opposed to an HRT, is that you've got your continuous ethinyl estradiol, that's your estrogen. which is not a body identical estrogen. 17-beta-ethynyl estradiol is the commonest used estrogen that's used so far, and a progestogen that inhibit FSH and LH production and therefore effectively inhibiting ovulation. So there's no ovulation, but essentially there's no 17-beta estradiol either, and FSH and LH levels stay low. But the skin and bone and connective tissues all have sex hormone receptors. You've just heard from Prof. Naftolin. The estrogen's got your estrogen receptor beta, and you've got your alpha receptors and your beta receptors. And this implies that hormones do affect these organs, but do hormonal contraceptives affect these organs in the same way as body identical estrogens do? That's the question. So what have we got? We've got various formulations here. We've got oral formulations, we've got vaginal rings, we've got patches. The estrogen type varies. We now have natural body identical estrogens coming in. But ethynyl estradiol is the favorite, the 17-beta ethynyl estradiol. And then there is estetrol. And it's important to know that you are talking about various doses. I lost my mouse. Here's my mouse. So estetrol is E4 and estradiol is E2. Now, just as a rule of thumb, I might as well tell you straight away that we are dealing with ethynyl estradiol, which is a very potent estrogen, and that roughly 10 micrograms of ethynyl estradiol is equivalent to about 1 to 2 milligrams of estradiol, which is equivalent to about 15 milligrams of E4 estetrol, which is the estrogen produced primarily in the fetal liver, but now is present in some forms of contraception and also in HRT, from HT. So what happens with ethynyl estradiol dose? Well, for a long time we have said, how low can you go? So it used to be 50 micrograms, and now what's considered to be a low dose is the standard dose, the 20 to 40 microgram, and the ultra low dose, which is the 20 microgram estrogen. There are some also 15 microgram ethynyl estradiols. So that's how low can you go still apply. What about the progestogen type? We have first generation, second generation, third generation estrogens. Some of them have got androgenic properties, others have got anti-androgenic properties. Somewhere in there should be drospirenone, which is also a third generation gestogen, and is certainly anti-androgenic. Okay, what about the estrogenic component of CHC? There's a whistling sound, but I think it's coming from outside, not here. The estrogenic component of the combined oral contraceptive pill is ethynyl estradiol, we said, as opposed to estradiol valerate. And here is the conversion that I told you about earlier. The advantages of combined oral contraceptives is that we can have uninterrupted sex, really, and safe sex, and that you're not open to conception during this time. But there are other advantages, other medical advantages, such as reduction in menstrual flow, reduction in ovarian cancer, reduction in endometrial cancer, reduction in colon cancer, and important that is there's a reduction in premenstrual dysphoric disorders. And then there are other advantages on skin, such as in acne, a reduction in endometriosis, and other small print advantages that one can have with oral contraceptives. So oral contraceptives, yes, are used for contraception, but they can be used for other medical conditions in order to achieve a result. So contraindications, history of thromboembolism, migraines, family history of breast cancer, this you are familiar with. And now we start talking about bone. So here we have got to, as a rule, just remember that bone is made out of mineral 60 to 70%, and there's an organic matrix, which is mostly made up of collagen. Types 1 is the major one in bone, 3 and 4 is in bone, but you find similar percentages in skin. For example, skin, the dermis is almost 90% collagen with other glycosaminoglycans in it and other molecules. And this is responsible for the tensile strength. So you've got stiffness, which is made up from your mineral, tensile strength is made up from your collagen. And we can now monitor what's going on quite easily by looking at various bone markers, and bone markers will tell us what's happening with osteoblastic bone formation level and what's happening with the osteoclasts, which are your bone breakdown indicators. Now, for osteoblasts, read fibroblasts in the dermis, and for osteoclasts, read macrophages for for the dermis, macrophage activities like osteoclastic activity. Okay, so and these tend to be deranged in metabolic disease. So one of the conditions that gets them to be deranged is in fact postmenopausal osteoporosis, postmenopausal osteopenia. We said that there are both receptors present, and mainly we've got effects which are ER mediated in bone, but also ER beta, and the exact mechanism of estrogen activation of bone through estrogen nuclear receptors needs to be elucidated, but I have to tell you straight away that the estrogen effects on bone is present in both men and women. It's important to realize that men have as much estrogen in the serum levels as women have in their follicular phase. And women have got quite a bit of testosterone, even more testosterone than estrogens, except that we men have got about six times more testosterone. So it's important to realize this. So bone remodeling depends on osteoblastic and osteoclastic activity. And we said that osteoblasts regulate bone mineralization and form the bone's extracellular matrix, including the collagen extracellular matrix. And osteoblasts have function in bone resorption. And if you look at how this balance is maintained, you've got these various bone formation markers here, which are now used clinically and for research purposes. Osteocalcin was the earliest one to be used, or BALP, and now there's extensive use of the propeptides that collagen bundles shear off as they are being formed. So you can measure urinary propeptides. These are the end bits of your collagen as it's being formed and as it is being bound together. On the other hand, you've got your prolines here and your pyridinium crosslinks. Pyridinium crosslinks are what keeps the three collagen bundles together, because collagen is normally fixed in bunches of three chains, groups of three chains, and the pyridinium crosslinks are there. And once the collagen is broken down, you get your pyridinium crosslinks turning up and teropeptides, and these are measurable. There are clinical assays now that can measure them. Hydroxyproline here, that's a measure of collagen breakdown as a whole, and so on. And there are others. Calcium is not very reliable. So if you look at what happens here in I'm trying to get rid of this in different parts of the menstrual cycle, you can see that there is a fluctuation in PNIPs, bone formation here, bone breakdown, another index for bone formation, and you get some variations happening here depending on the day in your cycle. So there is actually a fluctuation that is hormone dependent in women who are having a menstrual cycle, of course. And here you can see that there are differences in women who are on various doses of the pill compared to controls, and you can see that there's a difference in if you are on 30 micrograms, and remembering that the 30 micrograms ethanol has effectively blocked your own estrogen level, then you've got a difference in bone formation, a difference in bone degradation as well, with a worrying net deficit of about 30% in type 1 and 11% in type 3. This is one particular study. Here you can see another study was carried out using 30 microgram pills. Sorry, my mouse has got a mind of its own. And just to summarize this, to make it easier for you to follow, I constructed this table, and you can see that with 30 micrograms versus control, you have a difference in formation of 17.5% and difference of resorption of 18.1%. So what happens is that your bone remodeling varies depending on your resorption rate. So if your resorption rate is low, your bone formation rate does not have to be high. So it achieves the balance in this way. If on the other hand, your bone resorption is high, then your bone formation very often increases to try and catch up. And this is what happens. But with 30 micrograms, we see that there is a bit of a problem in that there is some doubt if there is adequate, if there's formation of bone, if the net bone mass is the equivalent of somebody who's not on the pill. So is the pill making your bone turnover lead to less bone? With 30 micrograms, there's not much of a difference, to be honest. But the difference is bigger if you look at the lower dose pills. And you can see that you've got 30 micrograms and 20 micrograms. Group A here are your 30 microgram pills. Group B here are your 20 microgram pills. Sorry, it's the other way around. So this is 20 microgram pills, 30 microgram pills, and controls. And this is preliminary cross-links. And so this is a breakdown of bone, basically. So there's a decreased breakdown of bone here. And there is also a decreased formation of bone here compared to controls. Controls always seem to be doing better than the 30 microgram pills over a period of time. And osteocalcin, also an index of bone breakdown. Once again, your controls are up here, doing slightly better in a non-significant way, however, to 30 micrograms and 20 microgram pills. The only thing of note here, I like to say, is 30 microgram pills in these younger girls consistently does better than the 20 microgram pill does. So what about estrogens in general? We know estrogens in general reduced osteoblast apoptosis, so osteoblasts hang around for longer, reduced oxidative stress, reduced NK-KB activity, increases cell osteoclastic cell apoptosis, so there's less osteoclastic breakdown bone available, and then they modulate various osteoclastic T cell regulation. We had the paper on this, and Rankelel is also induced, leading to an increased to a decreased differentiation of osteoclasts, and this trick led to one of the anti-osteoporotic drugs being developed, namely Prolia. So what about bone mineral density? Well, we have here some more papers here which show that if you look at the grand total 75 studies, I just take this slide for reason of time, then we've got if you've essentially got to break down your women into your healthy premenopausal women, anorectic premenopausal women, oligoamenorrheic premenopausal women, and perimenopausal women, and all these behave differently. So your pill, once again, your oral contraceptive pill has to be tailored to the sort of patient you are dealing with. So, for example, if you've got young athletes and who've got maybe poor diet, and who've got hypothalamic amenorrhea, they might have they might be in a stage of bone loss. And if you're on contraception, well, it's not really being that much looked into. Hormone contraception and bone mineral density in normal women there's not much data on this, but we do have enough data, and so we have to see what we have out there, basically. So you load those pills. Data is less clear with 35 microgram pills, but we do have data on 20 and 30 microgram pills, and we've got the same. So just load those pills. They tend to be more protective than 20 microgram pills. So if you're going to have young girls, probably better giving them 20 microgram pills. Other findings from RCTs by Chibula here showed ultra low dose pills may interfere with lumbus bone, mineral bone density, occurring in adolescence, interference in achieving peak bone mass. Current randomized trial here shows that if you switched 30 microgram pills followed by 50 microgram pill, then they were doing consistently worse with the 50 microgram eternizediol pill. In other studies, 30 microgram eternizediol pills was a selective increase in lumbar spine BMD, which was found as opposed to those women who were on 15 micrograms. So 15 micrograms was definitely too low in these young group of patients. But 6 months is too short a period of follow-up. This is one of the problems. I think we'll just move on. And this particular study by Liu and Lebrun was looking at premenopausal women and anorectic women. So of course, these women already had compromised bone mineral density. So any amount of estrogens would be a positive thing in them. And they did tend to increase bone mineral density. But these are selective groups of women, premenopausal women, where their estrogens are low, where they're already losing bone mass, anorectic women who have no estrogens at all because of hypothalamic amenorrhea. What about fracture risk? But fracture risk, it's even more difficult to assess. non-reported bone fractures out of 19 RCTs, non-reported bone fractures as an outcome. These were because they were looking at younger women and they hadn't followed them up long enough to see what was happening to their fracture rates. With perimenopausal women, we do have some data, however, coming from Marco Gambacciani, and we can see that if you are an older woman, giving them an oral contraceptive pill does actually help prevent bone loss and does prevent the decline in peak bone mass. Here we can see some of them, but these, once again, remember, these are older women in their 40s, okay, as opposed to the others where we had women in their 20s. And you've got your 20 microgram pills here being better than those who were on oligomenorrhea, who had oligomenorrhea a few periods. And calcium, these are essentially perimenopausal women who are doing better if they are on a contraceptive pill, on a 30 microgram contraceptive, or sorry, 20 microgram ethanol estradiol contraceptive pill with desogestrel. And this is why it's very clear to see why this happens here. Peak bone mass in a woman is achieved by the age of 30. So over here, you've got to be very careful not to use a low dose combined ethanol estradiol pill, low dose 17 beta ethanol estradiol pill, because you will inhibit the achievement of this peak bone mass here. So I think we need to rethink this. Whereas if you're using your pill on older women here, when they are already declining, sorry, here, when they're already declining, then that might be enough to stop and slow down your decline. But if they are achieving their peak bone mass in those first 30 years, it's very important to try and get them to achieve the peak bone mass that they are meant to achieve. So they, of course, look to look after anorectics, hypothalamic amenorrheic women in a different way, but even older cycling women can't afford to lose their own endogenous estrogens and have it replaced by an inadequate dose of ethanol estradiol, a low dose. And you can see here from HRT, these are older women, of course, postmenopausal women, and you can see that the, 17 beta estradiol, remembering that the conversion rate is about 10 micrograms for 1 to 2 milligrams of 17 beta estradiol. And you can see whether you use transdermal or oral estrogens, it didn't really matter. This is work from John Stevenson. They all improve your bone mineral density within a very short period of time. These were early postmenopausal women. Whereas if you are on no treatment at all, your bone mineral density gets into an accelerated level of decline, which has been already happening in your perimenopause, but accelerates postmenopause. So we looked at some data from our bone mineral density work, and we also did pro-collagen levels and cross-links levels, remembering the pro-collagen is bone formation and cross-links is bone breakdown. We looked at the bone mineral density of all these women. This was a cross-sectional data with large numbers of women, as you can see. So this was, the bone densities was independent. And when we look at bone densities in this group of women between untreated and treated, women had been treated for an average of about 2 years. They had 16.1% difference in bone mineral density. But it so happened that if you looked at the pro-collagen levels here, you saw that bone formation did slow down by minus 11.3% cross-sectional data, but bone breakdown, osteoclastic activity, was brought down, was decreased at a much more rapid level, much more significant level. These are all significant changes. And in fact, if you were to subtract bone breakdown from bone formation, you still get this magic number of 16.1% that we have here. So the 16.1% is independent to the 11.3 and 27.2%. So if you were to work out 27.2% less 11.3 bone breakdown, less bone formation, then you end up with a net increase in bone mass of about 16% as well. So these two figures were very, very similar. So we think that what's happening is that your bone remodeling unit is being set at a different speed, if you like. A massive decline in osteoclastic function, coupled with a less big decline, less large decline in bone formation. I hope this is clear. And this is as a result of women treated with body identical estrogens, okay? That means 17 beta estradiol, mostly 2 milligrams of progynova. sorry, of 70 beta estradiol, E2, should mention names. Okay, so here we go to a John Stevenson study, and you can see that he's doing the same thing with his vertebrate disc. This is the previous slide in a different mode, transdermal and untreated, and he looks at the femoral neck. Once again, untreated, do badly, but whatever way you introduce estrogens, you change that coupling mechanism. So here we're looking at collagen markers from bone, and then we're also looking at bone mineral density as another index. So what about muscle? Do the pills affect muscle? Now we know that with estrogens alone, we have 70-methyltretinoin, we have an enhancing effect of exercise. So postmenopausal women without estrogens can improve their muscles, but they can improve it much more with estrogens. And exercise alone will not compensate for a lack of estrogens. Well, does this happen with the pill? Well, there's a worry. Okay, so there are pills with high androgenic progestogens, and there's no real difference. Others have shown that there is a difference, and the difference, sadly, with low dose pills can be a negative one. And hence he looked at the fractional synthesis rate of collagen, how much collagen is produced during exercise, basically, with premenopausal women as opposed to control. These are very small studies, I'm afraid, but that's what we have. And what we saw in this very small group of premenopausal women on a 30 microgram pill was that there seemed to be a difference in collagen synthesis between rest and exercise, but the ones who were not on treatment, were normally menstruating, normally to their levels, were doing better than the ones who are on the pill. So this is small data, but it's just something for us to be aware. So what about other skin things? I might be talking about the skin. So, well, we know that acne is improved because you've got higher dose of SHBG in the pill. Any dose of pill can do that. Then you've got some particular properties with gestogens such as clospirinol, which is an NT5 alpha reductase, and this further reduces testosterone conversion to DHT. So acne improves. Sutis improves for similar reasons. High SABG from the liver blocks free testosterone. You end up with having less free testosterone, and hirsutis can improve. So once again, I'm just reminding you the conversion rate of 10 micrograms to 1 to 2.5 estradiol valerate. And why am I doing this? I'm doing this because we now have pills which have got natural estrogen. And we've got 2 pills on the market right now. I won't mention trade names, but 2 of them. Well, doesn't matter. That's Claire and Zerli anyway. And I definitely find interest in both. But it's possible to use the 2 milligram versions of these, which are 17 beta estradiol with a gestogen. And the gestogen continues just like in any other pill. And so you might want to select this mode. But once again, just be aware that 2 milligrams is not enough to achieve PBOMS in younger girls, okay? So you might have to use them in older women if you like. Although there's no contraindications right now to do this. Here's my original study, my first study on collagen, 1983, which showed treated and untreated women having a bigger turnover of skin collagen here. So this is hydroxyproline being measured, skin collagen formation, and the ones who were treated had significantly higher estrogen levels, had significantly higher collagen levels than the ones who are untreated. This was a BMJ paper, and this was using estradiol gel. We're using estrogel in the early 1980s in the UK, which was an exception because the French were using estrogen in those days, transdermal gels, but in the UK this was not very fashionable. We used implants here, hormone implants, and they're still of use in the UK and other places like Scandinavia or the States. In fact, we're getting our implants from the States, and you can see that it is possible to increase skin collagen even after you've lost some. So these are the ones on estradiol implants, 50 milligrams. Here, these are the controls. Even after 15 years, it's possible to increase your skin collagen content. This is looking at dermal skin collagen from your thigh, and if you compare it to metacarpal index, which was in those days used as a form of index for osteoporosis, so give us some idea of bone mass. And you can see that you've got the same story happening here. You maintain your metacarpal index, which is essentially a bone density marker, but you lose it if you're not on any treatment at all. regardless of age. Here you can see a prospective study using 50 milligrams here and 50 milligrams there, and skin thickness in this case keeps on increasing. Does it carry on increasing forever? So after 1 year, you've reached a plateau, which is the same essentially as your premenopausal levels. So your skin is healthier, it's thicker, it has more collagen in it, there's more elasticity in it. We will see in another study from a French study. So if you keep your estrogens going, particularly if you start them early enough, it is possible to reduce deterioration. But it's possible to even increase your collagen content in your dermis, even if you start late, although there are other types of damage that the skin might sustain. Okay, what about the carotid? It's another area of collagen here. The media in the collagen is virtually 100% collagen, and you can see and glycosamine is part of connective tissue, really. So when I talk about collagen, I'm also talking about connective tissue as a whole. So there are molecules there which are extremely hydrophilic and give us elasticity and shape. You see the controls here in the carotid artery. This is media thickness using a very high frequency ultrasound, oral HRT, about 2 milligrams of 7T beta estradiol, whereas implants here, you've got a nice linear increase in the thickness of your media. Other studies show your media is more elastic with estrogen, so you're less likely to get strokes. It was published. Stevenson did some work on intervertebral discs with us, and you can see that with 1 milligram and with 2 milligrams, you have a dose-related increase in vertebral disc height. And vertebral disc is pure type 2 collagen, and glycosaminoglycans doesn't undergo change with the menopause and doesn't undergo change with lack of estrogens, and doesn't undergo change once you introduce estrogens back. And it doesn't go change, but because you get angiogenesis and because you get a change in collagen from 2 to 3 if you're postmenopausal, 3 back to 2 if you've got estrogens, and 2 is much more elastic. But there is a dose-related increase. And from the last studies here that shows a dose-related increase in your bone mineral density, once again from Stevenson, but it's so elegantly presented here that I'm just repeating it. These are the same patients you saw on the previous vertebral disc ones. This bone mineral density, with 1 milligram, you get 1 increase, 2 milligrams, you get a higher increase, and then it plateaus out. So what's the take-home message? When it comes to the pill, we don't have any fresh data really, but the data does suggest that if you do give a contraceptive pill, remembering that peak bone mass is achieved at 30 years, I think it's prudent to use a higher dose pill, a higher dose estradiol pill, 30 microgram at least. And the thrombosis risk isn't that much higher anyway, and problems are only high in patients who are at risk. But in older women, once peak bone mass has been achieved, it does not seem to matter as much if a low dose pill or contraceptive pill is used. Just as the menopause, where HRT has dose-related effects on bone and on skin collagen, so also combined oral contraceptives, one gets the same dose-related results just from the data that we have, and other benefits on the skin using estrogens show improvements in collagen. You've heard Prof. Naftolin talk extensively about healing. We've got some data on healing as well, but healing is certainly improves in the presence of estrogens, even after a surgical cut, for example. And you have improvements with 7T beta estradiol. You find improvements in other skin conditions, such as acne and hirsutis. Both 7T beta estradiol and the choice of a gestogen, example, drospirenol or cyperostinate, play a part. So when you're choosing a gestogen, there are patient select criteria. So some patients might need better cycle control, for example. They need a more androgenic type of pill. Others might need more of a anti-androgenic effect, so you might want an anti-androgenic type of pill. And that concludes my lecture. Thank you once again, Professor Naftolin, for having us on to this SG webinar.
Thank you. Thank you very much, Mark. Now, my pleasure also to invite Fred to join us again, and we will start the question and answer. I invite all our public to send me the questions and to write the question in question and answer. We have a first question from Colleen Dye, and Fred, this is for you. Any thoughts on topical estrogen for the face and anti-aging?
You're asking me.
Yes,
I have no experience with it, but I would guess the same rules apply. you will get more hydration, and you'll get the same thing as you see on the arm when you use the cream. You get turgor and thickening of the skin. I think this is mainly due to hydration.
Thank you very much. And then also the same person, Colin Dye, is asking for you, Mark, as ethinyl estradiol is much more potent than estradiol theoretically, should it not be enough for bone density maintenance based on effect in postmenopausal women?
Well, 20 micrograms is the equivalent of 2 micrograms, right? So that is effective for postmenopausal women and perimenopausal women. But 2 milligrams is not enough for younger women. Now, if you remember, just from our IVF experience, for example, in order to suppress cycles in a freeze-all cycle, for example, we use 2 milligrams 3 times a day. Yeah. And sometimes we even go up to 4 milligrams 3 times a day. That's between 6 and 12. So no, the answer is that it's not enough. These younger women operate at higher estradiol levels to achieve their peak bone mass than the older women do. You know, so I think we need to be a bit careful because this has not been properly studied. But we know from our IVF experience, you know, we would never use just 2 milligrams for a freeze-all cycle. You'd use 2 milligrams 3 times a day to suppress ovulation, for example. And this gives you an idea. As regards to the cream on the face, we have to remember that there's a lot of solar damage as well, actually. And when people go sunbathing without proper sunblock, there's going to be solar damage, which breaks up your keratin and breaks up your dermis. So that's some damage you cannot repair. But estrogen creams do exist, yes. They've been shown to be effective as anti-wrinkling agents on skin. And a lot of cosmetic companies use our data in a way, you know, but actually, I'm sometimes not surprised to see our data being reported for the use of their creams, which are generally phytoestrogens. And there are some very popular French firms, which I won't mention here, they use phytoestrogen face creams for which are safe. The one proviso specifically say, do not use an alcohol-based estrogen on your face or on your vagina, especially in your vagina. It's really bad. They've got to be water-based. Otherwise, you're in trouble.
Thank you. And then Fred,
again, I have no experience with this, but I would think that somebody who is putting estrogen on their skin at regular intervals has to be concerned about endometrial cancer or endometrial hyperplasia. And I think that if the companies that are selling this for this reason don't put a marker on their label, that's reprehensible. And I think that we need to tell women that they need to be followed for it.
Thank you, Fred. And a question for you. If the vaginal tissues are mucous membranes, as you were telling us, do they respond to SERMs as described for estradiol?
Yes.
Okay, thank you very much. And
we know raloxifene does, you know, we know bezodoxifene does, yeah, and tamoxifen. We don't get vaginal dryness with them.
Another question for is related from Olga Starchik. She asks, is there a decrease of estrogen receptor in sex skin with age?
I'm sorry, I didn't understand the question.
If the estrogen receptor in the sex skin, then in the skin of the vagina or in the skin of the vulvar area are changed by the age process.
It doesn't seem so, although there have been a lot of supposition, but the fact is that clinically, a 90-year-old woman's vaginal mucosa will respond to estrogen quite well.
Yes, and then Mark, for you, please, what is the equivalent dose of 1 milligram of estradiol of beta 17 beta estradiol in micrograms of 17 beta ethinyl estradiol?
1 milligram of 17 beta estradiol.
Yes.
Well, 1 milligram is about 10 micrograms of ethinyl estradiol as a rule of thumb. I'm not sure if Fred would agree, but this is the reference I have. Now, some references say it's as much as 2, okay? but I always remembered it as being 1 milligram is the equivalent of 10 micrograms. This is based on studies on the endometrium and the effect on endometrium. So they're prone to some error, but 1 milligram is between 1 and 2, I would say.
Then thank you. Then Fred, another
So,
one.
so sorry. I mean 10 micrograms of
Yes.
17 beta estradiol is equivalent to 1 or 2 milligrams of 17 beta estradiol. Okay, I want to make that clear.
Then
And one is micrograms and the other one is milligrams. So we've got to be careful about our units because there's a lot of confusion out there.
Then you mentioned, Fred, a question for you. You mentioned dilantin. Is dilantin really a SERM? And what clinical evidence is there for this?
What was the word? Aspirame?
No, you mentioned that dilantin. Mentioned dilantin is
Dilantin, yes.
Yeah, dilantin. I'm sorry for my Italian pronunciation. Dilantin is really a SERM. And what clinical evidence is there for that?
It is a SERM, and if you are treating women who are taking dilantin and you look at their endometrium, you will often find that there is a activation of the endometrium, and when they stop taking dilantin, they get vaginal bleeding, a little bit of vaginal bleeding. Dilantin is a SERM.
Thank you. And another question for Mark Brincat. How does the effect of a levonorgestrel containing device differ in its effects to the ovarian cycle to a norgestimate implant?
That is a very important question, actually. Now, I'd like to point out in the past, we used to have medroxyprogesterone estate. You remember depot medroxyprogesterone estate? That had bad effects on bone because it causes bone loss. Medroxyprogesterone estate, because that suppresses your cycle completely. Now, norgestimate implants do the same. We don't know for sure, but it does the same. It suppresses your cycle. Not so levonorgestrel Mirena coils, levonorgestrel devices. Levonorgestrel in the device is too low to suppress your ovarian cycle. So you still get an ovarian cycle happening with a levonorgestrel device. So I'm a bit more reassured there, although, as I say, data does not exist. But the norgestimate might have the same problems that medroxyprogesterone used to have when we used to use it in depot form once every 3 months, or once every month, depending on your data. But I have to say, both are a very good form of contraception. They're very popular, and I think work has to be done though, especially in the younger girls who have not yet achieved their peak bone mass.
Thank you very much. And then also another question for Fred. Fred, you mentioned that estrogen, they can have a very important effect on healing. And we know a lot of dermatological process where the healing is absolutely needed by the patient. Do you know if estrogen have been used for that?
I don't know of any concerted effort to do this. I know there are some physicians who take this into account and even will start patients. The problem has been the concern over breast cancer, and this is a ill-founded concern. Estrogen does not cause breast cancer, but when you start to talk to people about using it for so-called ancillary purposes, the first thing you hear about is breast cancer.
Yes, but you know that also very recently a lot of data suggest that that estrogen alone are not the fundamental factor for the carcinogenic process, most when they are associated with gestagen. And then for that one, because I think that it will be a very important point in the future. And also, you mentioned that the keloid cannot appear in the genital area, keloid. And then, do you know if estrogen have been used for the treatment of keloids?
Tamoxifen has been used as a treatment for keloids very successfully, and I don't know of anybody who's used estradiol, but tamoxifen is used intradermally or even smearing it on the keloid, and you get regression. So I believe that since the active agent is the receptor, then there's a message there that we need to follow.
Thank you, because this is something very, very important. And then, dear friend, we are now approaching to the end. I would like to have a final message. You know, Fred, you show us how estrogen are a fundamental partner for so many action, also in that fantastic organ, which is the skin, who separe, and you have that concept of teguments and how estrogen are active on teguments. You know, we have difference between two genders, males and females. And certainly, and do you believe that these have the same effect in both gender?
I have no experience at all with this, and I couldn't say.
And what should be your final message to we are all more or less 90% of the people who went with us that are still there. I would like to ask you to make a general message on your talk.
Estrogen is really fundamental to good health and should be used wherever possible to avoid the lack of estrogen effect, such as what we heard from Mark and from what we've seen, the Lila Nachtigall's little picture about the vaginal mucosa. I think that there should be no woman who loses her ovaries prematurely, who isn't started on estrogen. And the only thing that I would be concerned about is that we must always have a concern for cancer, not because it's related to estrogen, but because people who are taking estrogen very often fail to have screening tests. If you are giving a patient estrogen over a long period of time, you should always screen for cancer as long as you are treating with estrogen, and longer if you stop.
Thank you so much. And Mark, you have made a huge mention about what is the importance of the estrogen for bone, but not only for bone, for connective tissues in any area. We have in one side the effect of oral contraceptive, who certainly modify the general concentration of estrogen and progesterone too. But we have also now linked to our difficult society life, we have an increased number of anorectic syndrome on hypothalamic pituitary amenorrhea and other pictures. And sometimes the people don't give sufficient attention to that. I would like that you make one, you express yourself on how we have also to evaluate the bone structure and the quantity of the bone mass density in this younger individual who remain for years in amenorrheic situation.
Right, it's important to realize that anorectics might recover from the disease, but not from the hypothalamic amenorrhea. This might last for years after they've recovered from the anorectic phase itself. So I think that's number one. Secondly, we have shown time and time again, many authors have, including ourselves, that the effect on bone is dose related. And you've got to think of a girl, a pre-30-year-old girl, as being different to a 40, 50-year-old girl. We've got to really, we're talking a lot nowadays of tailoring medicine to the individual. I think that's very important when it comes to HRT. I support what Fred said entirely in screening and screening, but we've also got to screen bone mass. And I screen my celiacs, for example, my hypothalamic amenorrheas, my anorectics. I screen them for collagen disorders and bone mineral densities. And time again, you find that these have got very low bone mineral densities, actually. And we have a particular group here, which are our thalassemics, thalassemia minor. But we'll forget about those for a minute. But there's an increasing group of celiacs which are forgotten about. And there's an increasing group of people who are asthmatic who've been on long-term steroids, for example. And this also alters their sex steroids. So these are particular groups of women who have got to be monitored very carefully, because once you reach your peak bone mass, that's it. Now, okay, we can modify it with HRT later on or with other anti-resorptive drugs, but we do know that our fracture rates are increasing. So despite whatever happens, our fracture rates have been increasing. There have been some great studies. I've got the graph in my head, but I can't remember the Kaiser Permanente study, right, which shows fracture rates are increasing steadily. And also, you remember, Andrea, that the breast cancer rates, despite stopping estrogens, despite the catastrophic drop in estrogens, still kept on rising. So this was, years down the road after we'd done so much damage. I mean, we didn't do damage ourselves. People who misinterpreted findings of damage. But after all that, we had a massive increase in fractures and a massive increase in now we had studies that showed, for example, that city dwellers had lower bone masses than village dwellers who lived in the farms. So yeah, I think you've got to give the right doses. And the right doses, got to be careful. The lower is not necessarily the best when it comes to younger girls.
Thank you very much. Dear friends, I would like to thank Fred Naftolin and Mark Brincat for that fantastic webinar where we have touched the new borders of the studies about estrogen effect on the mucous teguments in one side, and estrogen effects on healing process, and estrogen effect in the maintenance of bone mass density, bone structure, but also the effect on connective tissues. And I would like for that to thank Fred for his time and to thank Mark for this time. And I would like to invite all of you to the next webinar. Our next webinar, August in Italy is an holiday time. Then we will move from now to 11th of September, when we will have a webinar on polycystic ovary syndrome, new insight, with Alessandro Genazzani from Modena and Blase Mesekalski from Poznan. It will be a fantastic webinar. I invite all of you to come and to be with us the 11th of September, always at 3 o'clock Central European Time. Thank you very much, Fred, for the presence with us. Thank you, Mark. And I remind to all of you that the next Congress of International Society of Gynecological Endocrinology will be in Rome in March 2026. It will be the 14th anniversary of our wonderful society, and I invite all of you to be present with us, certainly Fred and Mark. Thank you so much. Enjoy and have a good summertime.